Hello, I am Megan Sainamore, and this is my patient case video presentation. I will present my case as though I were speaking to my clinical preceptor. I will now begin. Patient is a 79-year-old male. His chief complaint is that he has been experiencing dyspnea for 1 year. Patient noticed that his dyspnea started about a year ago and that has been slowly worsening ever since. His concerned wife convinced him to come into the clinic today. The patient experiences dyspnea at rest and noticed that it worsens with exertion and at night. He exhibits paroxysmal nocturnal dyspnea and requires 3 pillows to sleep comfortably at night. He also feels that he can't catch his breath and often runs out of breath when talking. He also has a cough that has been persistent for about a year and also notes that it worsens with exertion and at night. He finds that he coughs less when he is resting and when he is elevated. It is a dry cough with no sputum and no hemoptysis. He has no chest pain, but sometimes feels as though there is increased pressure inside his chest. He finds himself to be more easily fatigued and has noticed some muscle weakness. He occasionally experiences lightheadedness, but has not fainted. He has not been recently sick or experienced any fevers, nausea, or vomiting. He has no abdominal pain and has had no changes in his bowel movements. He also has no difficulties with urination, but has been experiencing nocturia for the past 6 months. His past medical history involves no major surgeries or hospitalizations. He also has not had any major childhood illnesses. However, he was diagnosed with hypertension 4 years ago and dyslipidemia 3 years ago. He is currently taking hydrochlorothiazide to treat his hypertension and atorvastatin to treat his dyslipidemia. However, he often forgets to take these medications daily and thus is not adherent to his medications. He does not take any over-the-counter medications, vitamins, minerals, or supplements, and he has no known drug allergies. His father had hypertension and passed away at the age of 70 from a myocardial infarction, and his mother had type 2 diabetes and passed away at the age of 74 of natural causes. Our patient is retired and lives with his wife. He was a previous insurance broker. He has 3 healthy children and 7 grandchildren. Lately, he finds he is unable to play or keep up with the children like he used to. He would often play catch outside with them or hide and seek, and finds that now he has to sit down and watch them instead. He doesn't get much physical activity anymore either. He and his wife used to go on nightly walks. However, for the past 3 months, he's only been going about once a week because he finds it difficult to keep up. He claims that he can climb 3 to 4 stair steps before having to stop and catch his breath, but also states that his diet is well balanced and that his wife ensures that he eats healthy. He is currently a non-smoker, but had previously smoked half a pack for 20 years between the ages of 18 and 38. He consumes maybe 1 beer or glass of wine a week on Sunday family dinners and does not partake in any recreational drugs. He has not been recently sick, in contact with any ill contacts, or has been recently traveling. His wife is very concerned that his cough and dyspnea have been slowly progressing, and it is starting to bother the patient that he is unable to play with his grandchildren and go on nightly walks with his family like he used to. Patient would like us to help him in gaining some of his previous functioning back, and also to help him in becoming more adherent to his medications. Upon physical exam, the patient looks well, but slightly fatigued. He does not appear to be in any respiratory distress, but does run out of breath when talking. His vitals are measured as a heart rate of 90 beats per minute with an irregular rhythm, a blood pressure of 140/90, a pulse oximetry of 91%, and a temperature of 36.9 degrees Celsius. His respiratory physical exam shows no chest wall abnormalities, no masses, scars, or lesions. He has no central cyanosis, but his fingertips and toes are mildly cyanotic. He has Cheyenne-Stokes breathing, where there are periods of deep breathing alternating with periods of apnea, and he also exhibits fingernail clubbing. Upon palpation, his trachea is midline, helping to rule out pleural effusion, and there is no tenderness upon palpation anteriorly or posteriorly of his chest. He has equal chest wall expansion bilaterally, and is negative for abnormal tactile phremitis, further helping to rule out pleural effusion. Upon percussion, sounds are resonant throughout. This helps to rule out any fluid or masses or air that may be present in the lungs that are responsible for his shortness of breath. And as well, his diaphragmatic excursion is normal, further helping to rule out pleural effusion or rule out atelectasis. Upon auscultation, vesicular breath sounds and late inspiratory crackles are present. There is no wheezing present, helping to rule out asthma and bronchitis. And egophony and whispered patriloquy are normal, indicating that there are no areas of consolidation within his lungs. His cardiovascular exam shows no visible heaves or pulsations, no venous or arterial ulcers, and no varicose veins. Upon inspection of the limbs for seeds, there is no swelling, erythema, atrophy or hypertrophy, deformities, or skin changes. Palpation of the apex beat was difficult to locate. Palpation of the limbs was non-tender, but extremities were cool. Capillary refill of the finger and toenails were slow, and peripheral pulses were diminished and irregular with a grade of 1. No pitting edema was present. Auscultation showed normal S1 and S2 sounds, but an S3 heart sound was present at the apex beat. Patient's JVP was measured and found to be elevated at 6 centimeters. For differential diagnoses, we can rule out pneumothorax and pulmonary emboli since his dyspnea and cough are not of a sudden acute onset. The differential diagnoses that I am considering include left-sided heart failure, chronic obstructive pulmonary disease, interstitial lung disease, and valvular heart disease. I am considering COPD because findings involve a chronic cough and dyspnea, which the patient has been experiencing for 1 year. However, there is no sputum or hemoptysis present, which can sometimes be found in COPD. Patient also has decreased exercise tolerance as seen in COPD, since he is unable to go on nightly walks with his wife, can no longer keep up with his grandchildren, and can only climb 3 to 4 stair steps before stopping to catch his breath. More specifically, he presents with crackles upon auscultation and cyanosis. However, his lungs are not hyperresonant on percussion, and the patient does not have a barrel or hyperinflated chest, which are indicative of emphysema. Lastly, patient was a previous smoker, which is a large risk factor for COPD. Interstitial lung disease is another likely diagnosis as it is associated with dyspnea, especially on exertion, a non-productive cough, crackles on auscultation, and clubbing, which are all signs and symptoms that our patient is presenting with today. Furthermore, interstitial lung disease also shares similar features with cor pulmonale, which is heart failure caused by pulmonary hypertension. Another diagnosis that I'm considering is valvular heart disease, such as mitral regurgitation, because patients commonly present with dyspnea, paroxysmal nocturnal dyspnea, and orthopnea. Physical exam findings of this patient are consistent with those found in valvular heart disease, including an S3 heart sound on auscultation and difficulty palpating the apex beat. This is an important differential diagnosis that I would like to rule out because valvular disease often precipitates heart failure, which I believe to be the most likely diagnosis. I believe that the most likely diagnosis is left-sided heart failure. This is because the patient is experiencing dyspnea at rest, during exertion, and at night, as well as orthopnea, and these are all consistent with left-sided heart failure. As well, the patient is producing a dry cough that is non-productive with no hemoptysis, and the history found that the patient is experiencing nocturia, which is also found in left-sided heart failure. The patient has peripheral cyanosis, slow capillary refill, late inspiratory crackles and vesicular breath sounds on auscultations of the lungs, an S3 heart sound on auscultation of the heart, and clubbing, and an elevated JVP, which are all findings consistent with left-sided heart failure. Furthermore, the patient is experiencing fatigue, muscle weakness, and lightheadedness, which are additional symptoms found in left-sided heart failure, as the heart is unable to pump out blood to the rest of the body and the muscles. If the patient does have heart failure, I believe that the most probable cause is due to his uncontrolled hypertension and dyslipidemia. Since he is not adherent to his medications, this would cause his heart to overwork and then eventually fail. hypertension, and medication non-adherence are known to precipitate heart failure. However, the most concerning differential diagnosis is lung cancer, because the majority of patients with lung cancer present with a cough, dyspnea, chest pain, and clubbing. However, they also present with hemoptysis, a major red flag that our patient does not have. Patient is also a previous smoker, which is another large risk factor for lung cancer. I believe that our next step for our patient should be to do a chest x-ray to help differentiate and narrow down these differential diagnoses. That is my presentation of my focused history and physical exam and my differential diagnoses, including the most likely and most serious diagnosis for my patient. Thank you for listening.